We'll be continuing our we'll be continuing with our class tonight. This second part here, we'll actually be discussing the surgical options to manage the degenerative conditions that we have spoken about last week. So we would have mentioned about the degenerative conditions. We spoke about terminal stenosis. We spoke about myelopathy, impingement on the nerve root, and impingement on the spinal cord, and the different disorders which can cause those impingements. Now, to manage these conditions, what we want to do is to remove any of the remove any of the factors that will be causing impingement on whether the nerve root or the spinal cord. So to do this, we have two approaches. We have whether it's the anterior approach or we have the posterior approach. So just to compare the two, the anterior approach is usually able to access levels C3 to C7, where there's safe removal of the anterior osteophytes. It allows for fusion of the space area for immobility, at least up to 10% incidence of subluxation with extensive posterior approach, and it's the only viable means of directly dealing with a centrally herniated disc. Now, disadvantages over the posterior approach will be immobility. At the fuse level, it may increase stress on adjacent disc spaces. And if a fusion is performed, some surgeons prescribe a rigid collar, whether the patient wears a Philadelphia collar for the 6 to 12 weeks. And also, multiple level ACDF can devascularize the vertebral body or bodies between the septums. So that's just to compare the two. Now we're actually going to break down the two approaches and to talk further about some of the surgical options that are available. So with the anterior approach, with it, as you mentioned, you can gain anterior access typically from C2 to C7, and it functions to decompress the foramen of the roots and the spinal cord. Now it's indicated for central herniation of someone who has bilateral symptoms. It's associated with discectomy or compectomy, decompression, and fusion. So it treats the anterior disease at this level, but is limited to less than or equal to 3 levels. So the options for this, you can do a ACDF or cervical disc replacement, and we'll talk a bit further about these different options. We have a small case. We have a 42-year-old warehouse worker who loads pallets and complains of developing neck and right arm pain. Subsequent weakness in right bicep and wrist extensors, and he has failed 12 weeks of conservative care. We have the MRI presented on this side, and we decided we'll go forward and to do an ACDF for him. So to do this, it requires us to have knowledge of a well-known knowledge of our anatomy, where we start with a transverse curvilinear incision made at the anterior triangle of the neck at the anatomical location. So along the incision line, we would elevate the platysma, divide with either Bovie, cautery, or Metzenbaum scissors. So below that level, the deep cervical fascia is identified and divided along the anterior medial border of the sternocleidomastoid. So the carotid sheath is a very important structure that we must be very aware of, and is located posterior to that sternocleidomastoid muscle. Why is it important? Because it contains the carotid artery, jugular vein, the vagus nerve, sympathetic plexus, these super important structures, which of course, if damaged, can be very harmful to the patient. So you can palpate for the carotid pulse and then dissect medially to the carotid sheath. So another way of identifying this carotid sheath is actually being aware of the immediate relations to it. So you have the pharynx medially, the parotid gland laterally, the infratemporal fossa anteriorly, and you have the prevertebral fascia posteriorly. So at least located behind the sternocleidomastoid muscle, and you can also feel for that carotid pulse, so that okay, we know this is our carotid sheath containing the different structures, and at least knowing the different structures that will be around it can help to identify it also. So there's also the recurrent laryngeal nerve that we have to be conscious of to not damage it, but lies in a groove between the esophagus and the trachea. So what we're going to do now is to retract these important structures, the trachea and esophagus medially, and then the carotid sheath and our sternocleidomastoid retract that laterally. So we can use Kittner dissectors and handheld fluid retractors to identify and to develop appropriate planes to expose our longus colli muscles, our prevertebral fascia, and underlying disc spaces and the vertebral bodies. So our level, the exact level that we're working on is going to be verified with our lateral C-spine X-ray with a bayoneted spinal needle in the interspace. So after we have identified and we are comfortable with the identification of the level we'll be working on, we'll use a bipolar cautery on the prevertebral fascia and the medial edges of the longus colli muscles longitudinally in the midline. So then we'll apply self-retaining retractor blades and then insert it underneath the fascia to retract our longus colli muscles laterally. Now we get down to the part where, so now that we have adequate exposure, we can at least see our disc space, or we can, sorry, not see our disc space, but we can see our vertebral disc. So we're gonna use a blade to incise this disc space, and using two different instruments, you can use a curette or the Kerrison Ranger to perform the discectomy. Going further, a vertebral body spreader or a casper pin distractor helps in increasing the exposure. So the posterior longitudinal ligament is open, typically by insinuating a nerve hook through the fibers and then expanding with a Kerrison Ranger. So the subligamentous space is then probed with a blunt nerve hook, followed by removal of any posterior osteophyte. Now, at some point in time, some persons can opt for using a microscope to help with visualization. Then we have our fusion. So the fusion is facilitated by placing a graft in the interspace. And there are different grafts that can be used. There's autologous bone, where you can use it from the iliac crest, or you can use from cadavers, or bone substitutes, or even synthetics using a titanium cage that's filled with osteogenic material. So the anterior cervical plating is recommended to reduce pseudoarthrosis rate and to maintain the lordosis level. So here, after we've applied our plates and applied our screws, this is a poster image of how the ACDF would appear. So what we'll do is at least maintain, so soon as we remove the disc, we have allowed the plates and screws to allow for fusion to happen at this level, and to be able to remove the disc that would have been causing compression on the nerve root or the spinal cord. So some complications of the ACDF procedure, we have recurrent laryngeal nerve palsy. So all those different structures that we paid key attention in trying to protect the pause with any surgical procedure, there are complications. So post-op, we have to be keenly aware of these complications that can arise. So recurrent laryngeal nerve palsy, a patient may complain of hoarseness, dysphagia, food and or liquid aspiration. There can be post-op cervical wound hematoma, where we'll need to come and try to remove the stitches, to remove the hematoma that may be causing compression, wound infection, perforation of our viscus. There's the trachea present, the pharynx, the esophagus. They can even be cerebrospinal fluid leak if we have, by some way, damaged our dura, spinal cord and nerve root injuries, and even failure of fusion and arthritis developing above and below the fusion. Next from that, another alternative to doing our ACDF is using the cervical disc arthroplasty. And this one used in particular situation where you use the artificial disc to preserve motion at the level of the discectomy. So you use it at the one level, cervical disc herniation or spondylosis, and helps to protect the motion, as I mentioned. So contraindications to using this procedure would be if the patient has ankylosing spondylitis or rheumatoid arthritis. It is greater than 3.5 millimeters subluxation on cervical flexion extension X-ray. It is diffuse idiopathic skeletal hyperostosis or severe spondylosis with bridging osteophytes or ossification of a PLL, spinal affection, or the patient has some metal allergy to components of the prosthesis. So these are some of the prostheses that are available. There's the Prestige ST with the stainless steel ball and trough design with vertebral body screws are used to fix its position in the interspace, or the Prodes C with two cobalt chrome alloy end plates and an ultra high molecular weight polyethylene inlay in a ball and socket configuration. So I just as we described the procedure before, we're going to use it as a point of reference, at least when we're discussing this. I won't go through the whole process from the start, incising the skin, etc. We're going to go down to the part where we have exposed our vertebral disc after we have laterally moved away our longest pulley muscles so that we can see our disc. We're going to remove that from the end plates, exposing the PLL with its subsequent removal. So in the event of significant spondylitic changes, we may use a power drill to remove the disc and any osteophytes. So the end plates are burned to make them parallel while carefully avoiding disruption of the cortical end plate surface. And generous bilateral foraminopathies are created and care taken to ensure removal of the unconvertible joints bilaterally. So after that, we're going to place our prosthesis. We're going to place our prosthesis there and secure them. So some complications now of this procedure, they can be radiculopathy, which is either residual or new, resulting from whether there's incomplete decompression or removal of the unconvertible joint when the patient flexes their neck. So remember, we have implanted that graft there. So if we don't decompress these unconvertible joints properly, radiculopathy can occur. And whether there's also improper placement of the implant. There can also be ankylosed joints resulting from whether we put too large of an implant or faceted trosis or occlusion. Lastly, we can also have implant migration where we need to convert to a fusion if more than a few millimeters of migration occurs. Next, we have looking at the anterior options would be the corpectomy. So this will be indicated where persons may have degenerative cervical disc disease, whether there's herniation or spondylosis with myelopathy or foraminal stenosis. So also for compression, which might extend behind the vertebral body. So with this procedure, we use the less where the anterior two-thirds of the vertebral body are removed. So after we've removed the vertebral body, we need to, of course, stabilize, where generally we use to help maintain alignment and structural stability intended to improve fusion chances. So interbody strut reconstruction options include whether you use a structural autograft, allograft, or synthetic devices. In addition, the reconstruction typically requires placement of the anterior cervical plate or screw instrumentation. Next, we proceed to look at our posterior approaches, where there can be posterior laminectomy and fusion, posterior laminoplasty, or we can even do a combination of the two using the anterior and the posterior options. So these are indicated, the process of the posterior approach involves removal of the laminae and the spinous processes. So this is indicated where we have multi-level pathology of 3 or more levels with myelopathy. where the anterior pathology is superimposed on a more significant cervical stenosis. There's a relative preservation of lordosis, and just as I use the example, we surgeons, our hands are very precious to us. They are quite pricey. These are our tools. So too, there may be persons whose voice is their tool and their source of income. So there may be some persons who may prefer not to use the anterior route because of a not willing to chance that 4% risk of the recurrent laryngeal nerve injury. So they may prefer, we may offer them, depending on the situation, a posterior approach. So with this posterior approach, we secure the head using our Mayfield holders in capital flexion, and the exact location is identified using a C-arm and marked, followed by a midline incision. So this dissection is carried down in the midline through the subcutaneous tissue and fascia to the tips of our spinous process. We confirm the location with fluoroscopy and place self-retaining retractors to maintain tension, whether we use a curve with Lena or axon vector. So the paraspinal muscles are elevated subperiostally from the underlying laminae using a curve elevator, and the subperiosteal dissection continues to the lateral margin of the involved facet. So looking at the posterior cervical decompression, now that we have exposure, we're going to look at the bone removal process. So the junction of the lamina and the lateral mass is identified to preserve integrity of the facet capsule. So thin lamina using the lamina serratus thin using high-speed Midax Rex with an AM8 bit. A small raunchy is then used to create troughs to level of the dura. So a curette or 10-footed kerrison can then be used to remove any ligamentous attachment to the lamina, after which we remove our lamina end block. So in addition to that, with the posterior laminectomy, we can do a posterior cervical arthrodesis, which would involve us placing screws in each of the vertebrae and then connecting them with rods. So chips of one's own bone or probably donor bone are placed along the exposed bones and around the hard bone to help promote new bone growth and fusion. There's also posterior cervical laminoplasty, where we have maintenance of cervical lordosis, not indicated if a patient has significant kyphosis or instability of more than 2 degrees, or greater than 3 millimeter of motion and cervical flexion extension x-rays. So we use the posterior cervical laminoplasty to treat persons with subspinal stenosis, where the procedure is performed on the lamina, creating a hinge and use a metal hardware to bridge the gap. So two options are available when we're doing our cervical laminoplasty. The first one would be the expansive open door technique. So here, a high-speed drill is used to create a trough at the junction between the lamina and the lateral masses on the open side. Now remember, I won't describe the whole process of exposure before. Now we have adequate exposure. So we are actually going in now to create a little trough using a high-speed drill. So a kerrison punch is then used to remove ligamentum flavum and expose the dura, and then use the same drill again to create a second trough on the opposite side. This closed side now. So we have the open side and the closed side. And on the closed side, the lamina are thin and we're not cutting all the way through as we did on the other side, on the open side. So each level is then opened by lifting the open side with a curette or Penfield dissector. And a ceramic or allograft bone space is typically placed to keep the door open, and a titanium plate is used to secure the pacer with a 3 or 4 millimeter screws placed into the lamina and lateral mass. Next, we have the French door technique, where the high-speed drill is used to create a trough at the junction between the laminae and the lateral masses on the both sides. So the laminae are thin, but they're not cut through. And the spinous processes of the operating levels are split in the midline using either a high-speed drill or a kerrison punch. After which the lamina are lifted away from the midline, and then we secure them using a suture placed through the facet joint and the spinous process. Alternatively, ceramic or bony spaces are placed and secured in the midline to keep the canal open. So this picture here would indicate the two different processes that we would have spoken about. So here you look at, we have the open end and there we have the closed end on this side, and this would be our French door technique here on the right. So this is also that we can open the space so that we can reduce the compression that's occurring on our spinal cord or nerve roots. Then we have cervical foraminotomy. And these are indicated in those with monoradiculopathy, with posterolateral soft sequestration, whether there's small lateral osteophytic spurs may also be addressed. Radiculopathy in patients who are professional speakers or singers, where of course the risk of recurrent laryngeal nerve injury is untenable. For lower C7 to T8 or upper C3 or C4 cervical nerve root compression, especially in a patient with a short, thick neck and anterior approach, will be a bit more difficult to do. So it's also indicated in patients with a herniated disc when it is desired to avoid a fusion, as would be done with an anterior approach. So there are two options. We have the open keyhole foraminotomy, where a high-speed drill is used to make an opening in the medial one-third to one-half of the inferior facet of the vertebrae above the desired disc space. And we're going to extend it slightly medially into the junction with the lamina. So once that inferior facet is penetrated, the superior facet of the inferior vertebral level will be visualized, and we are also going to tin this with the drill. Then opening is then made in the ligamentum flavum, overlying the lateral aspect of the spinal cord area, and the nerve root can be identified as it exits from the thecal sac. Now we can move this nerve root at least gently a few millimeters rostally and expect for fluidous fragments to begin in the nerve root axilla using the tool. Now, if this fragment is contained anterior to your PLL, this may be incised in the region of the nerve root axilla with a scalpel blade in a motion that's directed downward and laterally away from the nerve root and spinal cord. The small osteophytes can potentially be reduced using a small reverse angle curette, and spinal stability is usually preserved if less than half the facet joint is removed. There's also the MIS keyhole foraminotomy, where after having confirmed the correct level using fluoroscopy, we're going to use a 1 centimeter incision off the midline on the side of the pathology is made. A tin dilator then is inserted laterally and docked on the lateral mass. Progressively, we're going to use differently sized dilators to help to open the space, and above is used to expose lateral lamina and medial facet joint. So a straight curette is used to expose the inferior edge of the superior lateral lamina and the medial facet joint. Afterwards, the medial inferior and superior facets are drilled to expose the superior facet of the level below. So this completes the bony work. The soft tissue work will proceed as above, as we mentioned before, as this was described before in the open keyhole foraminotomy. So complications of doing the posterior approach, you can have kyphosis happening, nerve root injury. Of course, we always are concerned for infection and epidural hematoma formation or even cerebrospinal fluid leak. There's also the combined anterior-posterior approach in case the persons have fixed kyphosis or disc pathology in addition to pathology extending to the ventral surface. So I had the great pleasure of actually seeing this anterior-posterior approach done, where we had the anterior approach done first, and then we'd have turned the patient, to the prone position to do the posterior approach, the laminectomy. And here ends our discussion on the surgical options that are available for treating our cervical degenerative diseases. Are there any questions?